So my name is Harry Hyman. I have the pleasure of directing our DrPH program at the School of Public Health at Georgia State University. On behalf of the program and the school, happy to welcome everyone and thank you for joining us for our DrPH student applied practice experience presentations. We have three great students who will be sharing their experiences with three different community and agency partners. And I will introduce them more as we go, but as you saw on the flyer that was circulated, that includes Sam Clasp, who worked on a project with the Public Health Law Program at the Centers for Disease Control and Prevention, Kristy Joseph, who worked on a project at CDC and the Center for Global Health, and Carrie Oliver, who worked with ARCHI, which is the Atlanta Regional Collaborative for Health Improvement. So excited to share all three of those presentations with you. Each of the presenters will present for about 20 minutes, followed by about 5 to 10 minutes for Q&A and discussion. My request would be that you put any questions in chat directed to me, and that way I can review the questions and facilitate their asking, so that it doesn't become too much of a free-for-all. If you have general questions for me, you're welcome to put them in chat, and questions or comments you want to share with the audience, obviously, you can share them as well. But without any further delay, I'm going to turn things over to Kristy Joseph, who will be making the first presentation based on her work at the CDC Center for Global Health, summarizing the landscape of the CDC-WHO partnership. Certainly a timely and important topic. And I will turn things over to you, Kristy, and ask everyone who's not speaking to please put themselves on mute.
Thanks, Harry. And I will share my screen. Okay, good evening, everyone. My name is Kristy Joseph. As Harry mentioned, I'm a third-year DrPH student, and today I'll be presenting to you on my applied practice experience and summarizing the CDC and WHO partnership. Before I begin, just a disclaimer that this presentation does not reflect the views of the Centers for Disease Control and Prevention. So finding an applied practice was a journey in itself. Starting at CDC almost 10 years ago, I've been at a branch level, and I wanted to use this experience to see decision-making at a higher level. I'm on long-term training, so I'm a full-time student, though I'm a CDC employee. And I thought that this would be a great opportunity to see if I can go outside the box a little bit, outside of CDC, and do my applied practice in WHO headquarters. My mentor and previous supervisor is currently the Assistant Director General in WHO HQ. And she runs a Department of Metrics and Measurements and oversees WHO's 5-year strategy called the General Program of Work, currently in its 13th term. And this strategy aims to improve the lives of 3 billion people, called the Triple Billion. So I called her in late 2019, and we agreed that this could be a possibility for me to do my applied practice experience in Geneva. But as we all know, COVID-19 happened, followed by lockdown, followed by a lot of confusion if I could even leave my house, let alone get on a plane. So I scrapped that idea and thought maybe perhaps instead go local to CDC, since it's right here and there's been so many unknowns. So followed up with the Center for Global Health and to work on the WHO's Health Emergencies Program. This program collaborates with CDC to prevent, prepare, detect, and respond to outbreaks and other health emergencies. The initial plan was to evaluate the programmatic aspects of the health emergencies activities funded by CDC's cooperative agreements. I thought this would be a great opportunity because I have experience managing cooperative agreements, especially at the global level, and understanding more about health emergencies. My background is in chronic diseases, so this would be something outside the box and interesting, especially since we're in the middle of a pandemic. But almost a month before I was going to start, we learned that that the United States was going to leave the WHO partnership. And so it would have been very inappropriate for me to reach out to my CDC colleagues working in this area, because there's a threat that they could lose an important and critical partner, funding, and perhaps even their jobs. So that was also scrapped. Because of the amount of unknowns happening, right before my AP started, which was in June, talking with CDC, we decided to catalog and summarize the WHO-CDC partnerships and its implications of the US government withdrawing from CDC. So the purpose was to provide a broad landscape of the CDC partnership with WHO, serve as a reference for future decision-making and policy requests, and also catalog the CDC collaboration and the potential impact of the change in membership status. So while all of my other options I tried to pursue didn't work out, I was still able to fulfill my goal of working at that higher level, at this higher decision-making level. So some background on WHO, for those that may not know or have worked with them. WHO was founded in 1948 after World War II as a global health arm to the United Nations. WHO replaced several regional authorities that was established in the Americas and Europe in the early 1900s to prevent the spread of infectious diseases like smallpox. They have 194 member states, and the member states form the World Health Assembly. And they set WHO's policies, approves and supervises its budgets, and also elects the Director General to lead WHO for a 5-year term. It's governed by its member states and does not have the legal authority to enter countries without permission or to force countries to take its advice. Its budgets come from voluntary contributions from its member states or nonprofits like the Bill and Melinda Gates Foundation. It's headquartered in Geneva, Switzerland, but has 150 offices around the world. As a team lead in the Global Non-Communicable Diseases branch at CDC, I work closely with WHO headquarters and regional and country offices to develop and implement cardiovascular disease initiatives, like the one you see here called the Global Hearts Initiative. The initiative aimed to improve the care across the hypertension continuum in primary healthcare settings. I understood from this experience, WHO provided CDC as a US government agency access to countries to implement our programs, especially when there wasn't a CDC country office. We gained access to networks, partners and networks to disseminate the initiative. And WHO invited CDC to be part of work groups and committees to develop cardiovascular disease protocols and guidance. We were able to influence standards and norms because of the technical expertise we brought and the funding we provided. So we always had a seat at the table. But my level of insight was from this very narrow scope. This APE gave me the visibility to see the breadth and depth of the WHO and CDC technical partnership across the agency. So my APE was through CDC Center for Global Health in the Office of Strategy, Policy, and Communication. CDC has been working around the world for over 60 years, but in 2010, CDC established the Center for Global Health, recognizing that the domestic and global work cannot be separated. By establishing the Center for Global Health, CDC has embraced the importance of science and health diplomacy. It supports PEPFAR, fights TB, and scientifically supports the US President's Malaria Initiative, and also leverages its expertise in eradicating the global effort to eradicate polio and measles. The Center for Global Health manages the rapid response team to rapidly surge and effectively respond to infectious diseases around the world. And the center also manages over 60 country offices. And its flagship program, the Field Epidemiology Training Program, which trains a new generation of epidemiologists, similar to CDC's EIS program. This is just a snapshot of Center for Global Health, but gives you an idea of what they do. The United States formally notified the United Nations in July this past year that the US will withdraw from WHO. To leave WHO, the US is supposed to give a 1-year notice and pay any outstanding dues. The withdrawal was based on the current administration's belief that WHO did not adequately control the spread of COVID-19 or hold China accountable. The US may reconsider withdrawing from WHO if the administration finds that the organization made enough reforms. These decisions have policy, programmatic, and financial implications on the CDC and WHO collaboration. These implications must be mitigated to avoid any unintended derailment of decades of US government investments. Without WHO's collaboration, challenges will present and persist in allowing CDC to deploy interventions and devote resources to address public health topics and diseases. Questions still remain regarding how the United States government will engage with WHO. However, technical collaborations will continue until further notice. So for my APE, part of it was to identify and expand on the mutually beneficial partnerships, as well as the impacts or the implications of withdrawing. So this first slide kind of just talks to you more, I'll just talk to you more about the mutual benefit partnership that WHO and CDC has. So CDC's role and mission as one of the world's leading technical public health organizations involves global health activities that requires assistance from and collaboration with WHO. There are numerous ways in which CDC utilizes WHO to accomplish its global mission, including technical assistance to countries, developing and disseminating international norms and best standards, and convening and coordinating partners. The US gains from collaborations with international experts while contributing expertise in WHO-led forums. For example, WHO collaborating centers are institutions designated by the WHO Director General that form an integral part of the international collaborative network. CDC has hosted 23 collaborating centers through which our programs gain access to and influence over global policymaking networks and decisions. The CDC also supports the United States government's participation in WHO's policy-making processes, including the World Health Assembly, the Executive Board, and WHO regional committee meetings. CDC regularly participates as a member to of the official US government's delegation to the World Health Assembly and Executive Board. WHO is able to tap into a considerable amount of expertise and proficiency across CDC to inform policies, recommendations, and operations, ensuring that they are data-driven and of sound technical merit. CDC and USAID are the largest funders of WHO through cooperative agreements, supporting activities at the global, regional, and country levels. The cooperative agreements are typically established for 5-year periods, with awards made annually for work to take place the following fiscal year. The cooperative agreement, the comparative advantages of each agency are important and together make WHO-CDC collaboration successful. So the potential implications affect CDC and WHO equally and eventually may affect the global community. The withdrawal can diminish CDC's capacity and ability to prevent, detect, respond, and control infectious diseases in the short term, and potentially in the long term through the loss of access to global surveillance platforms, systems, and networks. It will create a need to leverage other multilateral partners and identify new partners to fill any gaps in program support and implementation, potentially slowing our capacity to respond to disease and conditions. In the short run, it'll also negatively impact WHO's program budgets and operations. Programs that have a collaborative and almost symbiotic relationship will lose a technical partner and leadership support. So this is both on CDC and WHO's end. It also undermined decades of investment and collaboration. So these are trying times everywhere, but particularly in CDC, where the public trust and our ability to work effectively with key partners have been greatly diminished. But I have 3 takeaways from this experience that I want to share with you all. One, while the decision to withdraw from WHO is outside of CDC's influence, being strategic with global partners to continue the progress on global work is critically important. Working at the global level for almost 8 years, a predictable day is uncommon because decisions change regularly and which alter timelines and program trajectory. And though I'm at ease at a fast-paced and almost chaotic environment, it's important to remember and to know how to motivate and reward colleagues and partners. And finally, though the US is one of the largest donors to WHO, funding, while it's important, it wasn't the most critical component to our partnership. The things that we can't quantify, like access to a system or a health minister or information, that's what helps protect lives and helps us do our job better. The withdrawal may have a domino effect on CDC's relationship, in which it will undermine the reliance on our expertise and CDC's ability to influence programs and policies. My APE was to document the collaboration and the potential impacts, but time will only tell about the actual implications and the road ahead for the agency. Thank you.
Thank you, Kristy. Appreciate that presentation and your shared insights. And now, and appreciate the applause icons. Now we're open to questions. So it looks like we're in intimate enough group. People are welcome to one at a time unmute and ask, or you're welcome to share a question for me with in chat. And let me maybe kick off with a question, Kristy, and that is kind of given what you've learned, is your sense that the sentiment among your colleagues at CDC in the Center for Global Health is that they need to be developing plans B and C for the different ways this might go forward, or that for right now things are kind of operating as usual?
Well, I don't think anything's operating as usual anywhere. Though I do think that to be very strategic with our partners and knowing the kind of, it's almost a symbiotic relationship with WHO, but the work still has to go on. So knowing that right now the work has to continue, and perhaps it's not the best scenario given that we're in a pandemic, but to find ways to move the work forward through other relationships or partnerships.
So one of the questions posed by Emily, who's one of your CDC colleagues, who's doing work in global health, is what your sense was about disproportionate impact of a decision to sever the relationship with WHO on particular programs. Were there particular programs or areas of work that are more sensitive to the WHO relationship than others?
Yeah, there has been a number of programs that have worked together with WHO since its inception, like polio, flu. So there, and especially with the respiratory diseases, given that we're in COVID, there's been definitely a disproportionate kind of wanting to keep WHO as a partner. But again, you know, we're a government agency and we have to do what is basically mandated for us. So though there's been some requests for kind of approvals for certain programs to still continue being funded, at least for this current year, you know, the pendulum is swinging very far to the right at the moment. So only time will tell if that will, if other programs will continue with the WHO relationship or not, if they'll make some, you know, some requests to keep it continuing on.
Thanks. David, did you have a question?
Yeah, I've got a question. Imagine it's 2 years from now, the US is withdrawn from WHO and we're past COVID-19, but a new pandemic starts in China. How does our withdrawal from WHO, how could that affect our response in the United States and our vulnerability to that, a new global pandemic as it begins to come out?
Yeah, I mean, I don't think you can even have to wait 2 years from now. It could happen anytime. But even if it happens in China or another country, the loss of access to our surveillance systems, that's going to be detrimental for us if we're not able to duplicate those systems in a timely manner. So that's kind of a threat that will happen if we're not able to put other systems in place or other networks in place.
Are you aware of any historical precedent to this kind of action?
Well, actually, in doing the APE, the only time that anyone has left the WHO membership was Russia. And I'm trying to think back, but I think that they never signed on in 1948, but then after Stalin died, they were able to come back in. So that was the only time that, you know, a country might have left and then come back in, but that was definitely different because it was a Cold War, communism, everything was very different back then.
Kristy, I'm wondering, do you have any insight on how this division has specifically affected our compliance with international health rules and the reporting requirements under that? Is that a mechanism that, despite the other barriers, we still participate in, or has the reporting also been cut off?
Well, nothing's been completely cut off right now because there's been a 1 year lag from when we actually make our withdrawal known to the United Nations to actually leaving. So it'll be July of 2021 when we actually officially leave. But the international health regulations that was established in 2005 requires that any country that are members of WHO report of any infectious diseases or report of any outbreak. But it's still unclear how that would all work out in a new reality without WHO's partnership. But possibly going back to David's question, we won't be privy to some of that information. But that all really just depends on other systems that we could possibly be put in place in lieu of WHO's systems and networks.
Kristy, can you talk for a minute about the CDC collaborating centers and both just kind of reiterate what they are and then how they would be impacted by a withdrawal from WHO?
Yeah, so the CDC collaborating centers are designated by the WHO Director General, and they are part of this international collaborative network. So it carries out the activities in support of WHO's programs. And CDC's hosted 23 of those collaborating centers. And we were able to gain access and influence over a lot of networks, decision-making systems in place. I am not sure what will happen to those collaborating centers once the withdrawal comes into place and what the role of CDC will be afterwards. That was something that was still unclear even after going through this, documenting the relationship and the potential impact. It wasn't clear.
Yeah, sounds like critically important functions for our ability to collaborate globally around things like pandemics. Yeah. Well, thank you very much.
Thank you.
We have a round of applause, virtual and otherwise, for Kristy. Yeah, thank you so much for that. And next we will turn to Carrie Oliver, who, as I said, did her applied practice experience at ARCHI, which is the Atlanta Regional Collaborative for Health Improvement. And she'll be talking about using systems modeling to center equity in the COVID-19 response.
All right, good evening, everyone. Hope you're doing well. Thanks for joining us. So as Carrie mentioned, I will be covering my applied practicum experience with ARCHI and where I use system modeling and systems thinking to guide their efforts around centering equity in the COVID-19 response. So just to start off, we recognize that COVID-19 has disproportionately impacted communities of color, specifically Black and Latinx communities. However, more so, the COVID-19 has provided a spotlight on many of the health inequities that we have been aware of for a long period of time. So essentially, when we look at these numbers, we see that Black and African American populations, along with Hispanic and Latinx populations, are disproportionately impacted by COVID-19 due to inequities in job stability, inequities in housing, inequities in wealth in general, as well as inequities to health access. So there were several factors in play to come together and create this conundrum of problems that we now see ourselves facing. Essentially, ARCHI saw itself and its work in a position to address not just the immediate response to COVID-19, but the long-term as well. So how could they be a part of bringing together partners to respond in a way that centered equity and ensured that this disproportionate impact didn't continue in these communities? So a little background on ARCHI. So ARCHI stands for the Atlanta Regional Collaborative Health Initiative. And so as you know, ARCHI is guided by, its principles are collective impact, and it's guided by 7 strategies, which are outlined here, as well as it has an actionable framework. So essentially it's looking for ways to create innovative partnerships, align systems to address health improvement throughout the Atlanta region. To give you a little background on ARCHI's history and their work and what put them in the best position to then be responsive to COVID-19 and ensuring that equity was centered in this response, in 2012, ARCHI adopted a 28-year strategy for health improvement. So I imagine that strategy was time intensive and it's going to take a lot of partnership. In 2013, the first 30 organizations joined ARCHI's efforts. And by 2019, they had their 100th partner as a part of their commitment. From 2013 to 2018, they did several programs, initiatives, and efforts that centered around equity. So in 2018 in particular, they had a year-long health equity series, which looked at health equity in the Atlanta region in regards to housing, race, transportation, as well as immigrant and refugee experiences. 2020, as we all know, the COVID-19 pandemic impacted not only Atlanta, but the whole world. And in 2020, I was able to help support some systems thinking as well as modeling principles to guide their work to ensure that equity was centered in their response strategy. Now, this systems thinking is not a new concept to ARCHI leadership, given that in 2012, to develop its 28-year strategy, it used a Rethink Health Systems model, in which 70 stakeholders were involved to come together and identify the interconnection between systems that ARCHI would want to impact, as well as potential outcomes of its work. So the guiding theories and principles that guide ARCHI, as well as my applied practicum experience, include collective impact. Outlined here, you see the 5 principles of collective impact. What ensures that collective impact, A, is a joint effort from all partners, is that there is a common agenda as well as a backbone organization. So ARCHI and its over 100 partners, ARCHI serves as the backbone organization for a lot of its work. So it is a neutral convener that brings together those partners in innovative ways to get them to think outside of the services that they directly provide and think more long-term. Also, a part of the systems modeling process was involving the social ecological model. As outlined here, it looks at interactions on the individual, interpersonal, community, and policy levels. And then lastly, it was principles of system modeling. So that includes systems dynamics, systems modeling, and systems thinking. So often those terms are used interchangeably, but here I've outlined a few of the differences. So systems dynamics is very much using computer or mathematical modeling to address a policy issue. So this approach looks at complex systems and is used across industries. So not just public health, but also business, as well as ecological systems. Systems modeling is the simulation of those system dynamic model. So essentially you're able to put starter data into the systems model and then show what happens if certain interventions are implemented. So for example, if you're looking at maternal mortality and you wanted to know what would be the implications of implementing an implicit bias training, you would put that into your model, and based off previous data, as well as data that is currently collected, the system would tell you what impact you would have on maternal mortality as a result of that change. Lastly, systems thinking, which most are more familiar with, looks at the connection and the interactions between elements in the system. So here you see the iceberg outline, which is often an image used to describe systems thinking. So we're looking at not just what happens in events, but also the system structure and the mental models that contribute to those events. So the Center of Equity in COVID-19 response was a joint effort between ARCHI as well as Transformation Alliance. Outlined here, you see the cliff analogy, which was developed by Dr. Kamara Jones, but was also used to explain ARCHI partners what upstream efforts would look like. So essentially, we want to get a point across the point that partners can deliver urgently needed services as well as moving people away from the cliff. So we don't have to just address the immediate impact of COVID-19, but also addressing some of these structural issues that got us to those communities being in risk, at a higher risk. The model is also looking to address racism and historic inequities that push those people of color closer to that cliff and put them at a higher danger of contracting COVID-19, being hospitalized, as well as dying. And also recognizing that there are large dynamic factors that impact this whole system. So essentially, we could not just look at healthcare, we could not just look at education, we had to look at the system as a whole. So to develop the model, it was informed by the group's expertise as well as their knowledge of the program. So many of the partners that are involved in this process are not familiar with systems thinking or systems modeling. They're often community level partners who do their work. So for example, if their focus is education, then of course they're addressing the fact that kids are now out of the physical school building, having to do virtual learning, as well as other needs that their families may have that may impact their learning environment. So it was getting them to think beyond the direct services and the needs that they're addressing and recognize that other issues could be addressed as well as we move forward. So the group completed a Google form around the focal point listed here, which is the disproportionate social, health, and economic adverse impacts that were exposed during COVID-19 pandemic on Black, Latinx, Indigenous, and people of color. So the group was tasked to identify causes, causes of causes, and root causes. So essentially getting them to start at the problem and think backwards systematically to the things that brought that problem to light. So their input helped to visualize the system as a whole, recognize the interconnected relationships and the factors that they thought were most important, as well as create a plan to move the group's discussion into action steps. So here we have a draft of the model that I shared with them. So essentially the systems model lives in another program. However, it's best to share it in a simplistic way. And during the meetings, I guided them through the model. So if you'll kind of follow me through the model, at the top here, you'll see that the socio-ecological model principles are outlined. So policy, community, organizational, interpersonal, and individual. To the left of the model, their focus was on economics, education, as well as health. So those are the three buckets of policies that we looked at. Everywhere on the model that you see a green arrow would be the flow of funding. Everywhere on the model where you see a box that is outlined in dashed lines, that recognizes that that element may live in two different sectors of the social ecological model. So from education policy, essentially it's simplified, because one thing in developing the model is also recognizing that your model cannot include every element. So it's recognizing which elements are most important to your stakeholders, which are easiest to use as leverage points moving forward, as well as which are easiest to operationalize. So this model looks at funding as well as other resources from the education lens, recognizing that that funding travels from the policy level to the community level through school district funding, then down to the organizational level to school funding. On the organizational level, it's then broken down into personnel funding, which influences teacher wage. The other funding can influence teacher composition as well in regards to the resources that may be available in a school, and thus make it attractive to new teachers. Essentially, all those elements on the individual level contribute to the academic achievement of the students. From an economic standpoint, it's recognizing that economics flows into the business as well as the housing development in an area. The fact that also the school environment and the amount of resources in a school can influence business development. Also recognizing that housing development is interchangeable with business development, in that neighborhoods that have many new businesses may have new housing as well. Understanding as well that the composition of the community influences the housing development. So family median income will then flow into housing development. Also, the housing development has an influence on housing conditions, which also feed into the physical wellness and the mental wellness of an individual. On the economics level, it's recognizing that employee wage influences what a household wage or median income may look like, and that employee wage is influenced by job attainment and job security. Also, that on the physical and mental wellness goes into our overall well-being, but those are influenced, of course, by access to healthcare, neighborhood safety, and accessibility to affordable and healthy foods. At the bottom of the model here, you see civic engagement. So the group really highlighted that there are opportunities for community members to be civically engaged. So whether that be in their local community, on the state level, or possibly on a higher level, but also recognizing that that civic engagement is not dictated by their education level or their wealth. It's a personal action. So that's why it lives at the bottom of the model and stretches across each of the social ecological levels. Now, aside from modeling the system, the group was also interested in looking at where does racism and systematic racism play into this model? So where does it become a factor or a problem? So the second model that was developed, every red arrow that you see is essentially the place where systematic racism could have an influence. In addition to looking at systematic racism, the group also wanted to look at the COVID-19 response. So an opportunity to show them visually that what we're doing for a COVID-19 response may not be exactly what we need, and it may need to be expanded. So when looking at the COVID-19 response, you see here that many of our efforts have focused on the school environment, housing and business, as well as healthcare, but more on the physical health and the mental health aspect of well-being. Additionally, we've seen a lot of efforts put into, or a lot of attention placed on job attainment and job security, because often those essential workers are at a higher risk for COVID-19, given the conditions of their employment. So in developing the model, a couple of things were gathered. Next, ARCHI plans to use the model to continue to guide its stakeholders to be action-oriented. So now that they have identified that I can't stay in my education bubble, I can't stay in my healthcare bubble, but I have to work across these systems, helping them develop plans of action. Also, ARCHI is looking to refine the model because many of the stakeholders, after seeing the model, wanted to use it for a conversation piece. So if I want to talk to other partners about collaborating or doing innovative efforts, how do I help them understand the value of that collaboration? Often the systems model showing the interconnectedness can show that there's opportunities for everyone to work together. Also, the model shows the complexity of the issue that we're dealing with. So we can't fix this problem with one simple solution. It's going to take several. ARCHI is also looking to partner with other members who are working on similar efforts. So Neighborhood Nexus is working on a community atlas, and they're hoping to use the model as topics that they can move forward with and then support with data. So adding that dynamics piece to it as well. Additionally, the model will have dynamics added to it so that it can be used for policy implications. So as the group moves forward to develop policies and interventions to make sure that the COVID-19 response is centered in equity, using the model to show the value of those efforts. As for me, I will continue to be involved in this work. Now that Catherine has allowed me to participate, I still want to be a part of the systems thinking as well as the model development. Learning, I guess my biggest lesson from this project is learning that in order to be an effective leader, especially in a time of a pandemic, you have to be adaptable. So originally, Catherine planned to do other efforts, but she was willing to listen to the group willing to listen to the stakeholders and ensure that their priorities were also prioritized. So ensuring that they guided the efforts, ensuring that they were actively involved, and ensuring that there was active feedback. So they were involved in the model development, as well as they will continue to be involved in the model's refinement. So in closing, I want to thank all the ARCHI partners and stakeholders who actively participated in this process, as well as Catherine, Robin, Odetta, and Meg, who are members of the ARCHI team and Transformation Alliance, for their guidance and their support through this development. And I'll open it up to any questions.
Great. Thank you, Carrie. Can you stop your screen sharing so we can see everybody again? Perfect. Thank you. So to start us off, obviously critical to informing this was making sure when you brought stakeholders together that you had the right people at the table. And I would say especially given the focus on equity, that you were able to have authentic community voices at the table. Can you talk a little bit about who made up the stakeholders and kind of what steps you and the team made to make sure that the right people were engaged in the process?
Yes, so initially the initiatives were volunteer-based in that ARCHI members were able to volunteer and say that they had an interest. After the initial meeting, they were then tasked to identify any individuals that they felt should be at the table who were not present. One thing that was also, I guess, an equal concern was ensuring that representation was dispersed. So ensuring that one organization didn't have 4 people who were showing up to the meeting while another only had 1 or didn't have any representation at all. Moving forward, a lot of the efforts will be placed on developing affinity groups. So once again, tailoring to the interest level of ARCHI members. So it's also recognizing that this project doesn't seem or may not seem as an immediate need to the things that they're doing in responding to COVID-19, but it's still of a high importance moving forward to ensure that their work isn't in vain.
Thank you. Other questions or comments for Carrie? So I have one more, and that just has to do with centering on equity. I know being familiar with ARCHI and being part of their collaborative, that ARCHI has thought a lot about how to integrate health equity in their work. Out of a lot of their work in 2018, there were recommendations about centering racial equity in that work. Obviously, structural and systemic racism has had an important light shined on it with recent events. How are they thinking and framing equity right now as they think about this?
I think one thing that ARCHI is keeping at the forefront is that they're not new to the equity talks. So as you mentioned, they've been a part of these efforts and these initiatives for quite some time. So they recognize that equity may not be the new idea that everyone thinks that it is given our social climate, but instead recognizing that some individuals may be new to these discussions and new to this train of thought on how to address equity moving forward. So I think they see themselves as a subject matter expert, but also positioning themselves in a way that's open to the idea that many of their partners or some of their new partners that may come from new efforts may not recognize the importance of equity. So it has been an integral part of their work from the beginning, which is one of the reasons why I was interested in working with ARCHI. But I think it's also recognizing that it may be a new hot topic to some, but systematic racism has been something that they have been addressing since their start, since their efforts moving forward. It's been a part of their plan. So recognizing that while it may be new to others, they've been an integral part of the work.
Great, thank you. So I have a question from Andre. So question from Andre is, if you could pose an equity-centered question in regard to policy to either of the presidential candidates debating tonight, what would that question be?
Well, Andre, that's a great, interesting question. One of two things. A, I'm not really here for politics. That's not my game. But B, I think that equity has been a point of just discussion. I think that recent social events and the recent social climate have caused people to have a lot of conversations. But essentially, to me, as someone who recognizes that systematic racism has been a part of my life since birth, I know that these things are not new and these problems are not new. So my question to them would be, what action steps do they plan to take moving forward to address these problems, and who do they plan to involve? Because oftentimes these efforts are led by those that are not impacted by these problems the most.
Carrie, that was awesome. Thank you.
Thank you for that.
That was great.
Yeah. A round of applause from your colleagues and friends. Well, thank you very much. And a round of applause for the presentation. Thank you so much for that. And thank you. I see a number of your and our ARCHI partners are here as well. So thanks to them for supporting you and for partnering with us. And we'll now turn things over to Sam Clasp, who, as I mentioned, was at the Public Health Law Program at the CDC, where his applied practice experience focused on policy options for improving infection prevention in skilled nursing facilities using communicable disease reporting requirements. Needless to say, another incredibly timely topic given what's going on in the world today with the pandemic. So I will turn things over to you, Sam.
Thank you.
And you should be able to
share my
screen share.
Let's see. Okay. Good afternoon. Like Harry said, my name is Samuel Clasp. I am currently a third-year DrPH student with the first cohort of this program. And I'd first like to start with a CDC disclaimer. The findings and conclusions in this presentation are that of my own and do not represent the views of the CDC or the Agency for Toxic Substance and Disease Registry. So today I'm going to give you just some overview of my project and my time that I spent with the Public Health Law Program at CDC. So I'm going to give you some agency and office overviews, some of the trainings that I participated in, the leadership and office insights, as well as a project overview, and then I'll open it up for some question and answers. So I'd like to start by saying I did my practicum experience at the CDC, Centers for Disease Control and Prevention, within the Center for State, Tribal, Local, and Territorial Support. And I did it within that center in the Public Health Law Program. The reason I chose, first of all, to stay at CDC was out of convenience. Most of us within the program are working full-time, as well as doing the program full-time. So it was easier to network and leverage some of the contacts at CDC to do my APE within CDC. I participated in the formal intern and practicum program for the spring cohort of 2020 within the Public Health Law Program, which included 5 interns in total, 1 JD or Juris Doctorate student, 3 MPH students, and 2 DrPH students. My preceptors there were Montrese Ransom, who is a lawyer and public health practitioner, and she serves as the team lead for the Training and Workforce Development Group, and Tara Ramnathan Holiday, who was my lead preceptor, and she served as the team lead for research and translation. So why did I decide to do my APE with the Public Health Law Program? The reason I chose to do my APE there was based on previous knowledge of their work and some familiarity with their leadership. Also, I have a personal interest in the intersection of law and public health outcomes, and their office's contribution to that space made them a prime candidate for my learning experience. I was also especially interested in learning more about legal epidemiology, I had had some exposure to it in previous work and projects, but I wanted a more rounded foundation on the topic and how to actually apply it. And I thought that additionally, the opportunity would be great for increasing my networking circle, and it could be advantageous for career development and advancement. So the first thing I want to discuss is the legal EPI training, just to kind of give some background for those of you who may not be as familiar with this topic. So what legal EPI is, it's the scientific study of law as a factor in the cause, distribution, and prevention of disease and injury in a population. So essentially, it's how the laws affect health and health outcomes. So who primarily uses legal EPI? It is utilized across public health by lawyers, non-lawyers, people who work with public health policy, and others who have an interest in how law may affect their different public health subject matters. Legal EPI is used for a myriad of reasons, including solely for research, for the background or scoping of policy creation, and it is primarily used to answer questions about law and its impact on health and healthcare. Legal EPI or its principles are used in many ways, either through legal EPI analysis, around a subject matter or a particular question, through using pieces of that process for targeted research, or in scoping projects or policy background. So before we get into my actual topic area, just some of the leadership and office insights I gleaned from my time there. One thing that kind of stood out to me was that the office was very diverse in terms of age, race and ethnicity, gender, and educational background. While a lot of those there had law degrees, JD, some had scientific research degrees, and one even held an MD. So I thought it was interesting how the different career paths all brought them to the PHLP, where they were able to offer those insights into the work that they're doing. Another thing I found interesting was the collaborative nature of the work. While the teams within the office were split into different groups based on subject matter area, they still worked across sectors with each other. So they leaned on each other's expertise, even if they didn't work within the same team or group. Another thing that I thought was important was that the leadership really empowered their staff. So they wanted them to go out there and be innovative. They didn't micromanage them, and they really empowered them to be authorities in their field. So people that dealt with housing, disaster management, emergency response, public transportation, several people held subject matter expertise on a wide range of topics, and that was really empowered by their leadership. So to talk a little more about my project, as Harry said, was entitled Policy Options for Improving Infection Prevention Facilities Using Communicable Disease Reporting Requests. And the reason I chose it specifically was that, as we all know, proportionately impacted nursing across the US, resulting in the sickness and death of thousands of patients and healthcare workers. So I really wanted to take a look at how we could leverage these reporting requirements that are already in place to improve infection prevention so that this doesn't happen in the future. So I had two primary objectives, which was to define the communicable disease reporting requirements in all 50 states, Washington, D.C., and the US territories, as well as propose policy options based on my research that policymakers at the federal and state levels could use to improve infection prevention at nursing homes, and it would be anchored by those communicable disease reporting requirements. So for those who are less familiar with this particular healthcare delivery model, a skilled nursing facility is a healthcare facility that provides a wide range of personal and healthcare services, and it kind of falls under that umbrella of long-term care facilities. So when we think long-term care, we're thinking things like skilled nursing, nursing homes, assisted living, or other long-term rehab facilities. Currently in the United States, there are about 15,600 licensed skilled nursing facilities, and that holds about 1.7 million licensed patient beds. There are many other nursing homes or nursing facilities that are not licensed by the Centers for Medicare and Medicaid Services, or CMS, so they don't factor into the official count, but there are many more throughout the US. Some of the general services that are provided by SNF are nursing care, 24-hour supervision, therapies such as physical, speech, and occupational therapies, as well as other nutritional services. So for those that aren't aware or weren't fully aware of the impact of COVID in nursing facilities, the very first outbreak of COVID in the US occurred in King County, Washington State, and it was in a skilled nursing facility where over 125 patients and healthcare workers were infected, resulting in the death of 23 of those people. This went on to spread across the US through many other skilled nursing facilities and has resulted where we are today with over 200,000 people dying of COVID-19. As of August 1st, that's the last time I updated the information for this presentation, there were over 260,000 confirmed or suspected cases of COVID within skilled nursing facilities, and over 60,000 nursing home deaths in both patients and healthcare workers. So we can see that these are staggering statistics, and these show that nursing homes are really disproportionately impacted by COVID-19. So for my first objective, I wanted to define what the communicable disease reporting requirements were, as I said, in the 50 states, Washington, DC, and US territories. To do that, I utilized Westlaw, which is a legal search engine where you can find laws at the federal and state level, as well as for US territories. And I utilized a combination of search string terms, such as healthcare facilities, communicable disease reporting, and communicable disease reporting, and I phrased them and bunched them together so that you can really hone in on the words we were looking for. And we really were scoping the laws that fit the scope of analysis, and then I saved those laws to go through and thoroughly identify them to see if they fit the description. Based on that methodology, I came up with these results. Information for US territories was not readily available, and for Puerto Rico, the information was unclear. But for all 50 states and Washington, DC, it showed that the state or local health departments did require healthcare facilities, of which skilled nursing facilities fell under, to report certain communicable diseases, especially those that happen in clusters of outbreaks. And what we really used for this was that the scoping for most of the laws included there were emerging infections or clusters of outbreaks, which many of these happened in, and at the various state or local levels, they defined what an outbreak was, ranging from 3 patients up to 7 patients, which all of these states fell in. So we were comfortable in knowing that all 50 states and DC required at some level, either the state or local, for reporting of a communicable disease. For objective number 2, proposing a policy option that lawmakers or policymakers could use at the federal or state level to improve infection prevention, we anchored those within that communicable disease reporting requirement, and I utilized the foundation of CMS, or the Center for Medicaid and Medicare Services, Skilled Nursing Facility Prospective Payment Service system, which is a annual reporting, annual rule that comes out for that healthcare facility type, which breaks down the payment systems and how money from the government goes into nursing home. And it also gives several criteria they need to meet in order to receive prospective payment under Medicaid and Medicare. And the very important thing to know about CMS is because it leads the way in insurance payments, where CMS leads, usually all other private insurers follow. So many of them hold healthcare facilities to the same prospective payment systems as CMS would. I also utilized CMS conditions of participation for skilled nursing facilities, which engages skilled nursing facilities on aspects other than payment. So it really hones in on infection prevention, quality of care, and how patients report their experience there. So based on these things, I came up with the 4 policy recommendations. The first one was to link communicable disease reporting to facility reimbursements for Medicare and Medicaid. So what we thought it was important was that if a facility knew that they had an issue with communicable diseases within their facility type, if we were linking that to reimbursements based on how well they were doing in terms of infection prevention and control and environmental cleaning, it would help to ensure that these facilities were preventing the spread of disease and that they were working diligently to identify and contain diseases, and also ensure that they reported these outbreaks to necessary oversight agencies, which will flow into my second recommendation, which was to link communicable disease reporting to accreditation status. So there are many oversight agencies that deal with the accreditation at a state and federal level, and which the Joint Commission, or JCAHO, is one of the most important, and they are the ones that license skilled nursing facilities for CMS. So ensuring that you have a facility that is accredited means that you can receive reimbursement by Medicaid. Those other facilities that I mentioned earlier on that aren't licensed under CMS and are unable to receive Medicare and Medicaid dollars and are usually private pay facilities. So the addition of this component that linking communicable diseases to their accreditation status will help to ensure these are adhering to federal and state requirements as well as accreditation requirements. If there's failure to meet the standards, that could result in citations, fines, and for egregious violations, it could result in the loss of your accreditation, which means a loss of a very important revenue stream. So that's a very good deterrent for skilled nursing facilities to really control these outbreaks within their system. Furthermore, the third recommendation I made was that we should publish the communicable disease reporting details in CMS's Nursing Home Compare. Nursing Home Compare is a government-ran website that lists the licensed nursing homes within a particular area. So you can search throughout the nation by zip code, by city, and it will list the different skilled nursing facilities available to you, and it will rank them on multiple criteria, including their accreditation status, whether or not they received recent citations for health or other issues, how they do on overall surveys by patients. And I'm proposing that we add a component for infection control. So this makes it public so that outbreak information will encourage, knowing that this information will be published, will encourage skilled nursing facilities to ensure compliance of disease reporting, as well as ensure that diseases within their facilities are prevented, detected early, and contained quickly as possible. And a lot of these recommendations come from a little further investigation, knowing that a lot of these skilled nursing facilities were not doing what was needed to prevent outbreaks, and they were not reporting these outbreaks in a timely fashion, which led to a cascading effect and more patients and healthcare workers putting their lives in jeopardy because of COVID-19 and other communicable diseases. And lastly, my last recommendation was to require an individual infection preventionist at each facility to oversee environmental cleaning and ensure adherence to CDC infection prevention guidelines. So currently, as written, the CMS requirements do not require an individual infection preventionist at each facility site. It requires that one company or organization has an infection preventionist on staff, which means if you have a large organization that has 50 sites, they only require one infection preventionist for that entire company, which we can see is a severe lacking because depending on where your skilled nursing facility is, they may have unique needs for environmental cleaning or other factors in the area that make it more challenging to mitigate infections. So really honing in and having one infection preventionist at each facility would really help ensure that there's a dedicated person in charge of that and that it will enhance specific adherence to different guidelines, one of which would be the communicable disease reporting, as well as CDC's infection prevention guidelines for skilled nursing facilities. And this was the end of the recommendations that I made. These are not official policy points that were made, but based on my research and the research done to find the communicable disease reporting requirements and my research on skilled nursing facilities, as well as the conditions of participation, these were the policy recommendations I came up with that to me made the most sense for really improving infection prevention and protecting patients and healthcare workers in the future from COVID-19, as well as other communicable diseases. And I will turn it over for questions now. You're on mute, Harry.
Yeah, thank you, Sam. I'll thank you now.
Thank you.
For that presentation. And now we're open to questions. And while you're thinking about questions, I'll ask one. So one of the challenges with COVID-19 has been a lack of kind of state level infrastructure and support for nursing homes and other long-term care facilities. And in particular, I'm thinking about capacity for testing, availability of PPE. So even if there are recommendations coming from CDC or other sources, the ability for some long-term care providers to actually follow those recommendations has been challenging. And I'm wondering specifically about the equity implications of, so for example, and it's a problem we have in healthcare in general, if you tie payment to meeting certain quality indicators, but let's say, you have a long-term care facility located in a community that's being disproportionately impacted by COVID. So the workers who live nearby are in an area with a high concentration of infection. They're more likely to be infected, more likely to bring that infection to the facility. And then we have a recommendation that the facilities do reporting and that their payment may be tied to whether or not they're effective at preventing infections. It gets complicated, obviously, but I'm just wondering what your thoughts were about some of the equity implications about things which at face value seem very common sense, but yet may inadvertently actually punish those facilities taking care of low income and Black and brown residents.
Thank you for your question. I have a couple of points to that. So first, I think that the oversight starts at the top, and what we see now is a trickle-down effect. Previously, as early as, I want to say 2019, there was a requirement that infection preventionists were located at least part-time within each facility. And under the new administration, there were changes to reduce the burden on healthcare workers, which inadvertently left gaps that allowed for infections to spread in certain communities. And like we know, those communities who have the higher disproportionate rates of COVID also in with healthcare providers. So I think it really is a balancing act of preventing unnecessary harm, but still holding to a certain standard. Those same communities of which we see time and time again health equity challenge, they did receive disproportionate burdens of COVID within their healthcare workers and their patients. If more had been done on the front end, or that prevention was being held at a higher standard, I think this could have been mitigated. Of course, now that we're in the middle of a pandemic, it is harder to say that these could be implemented at first effect, when in reality, I think it will, but I also think it is the role of the government through CMS, Medicare and Medicaid services to help ensure that these facilities that already are overly burdened and help and assistance at the state, local, and the federal level to help offset these potential adverse reactions to policies such as this meant to help, as well as moving funding away from unnecessary changes that have not helped or have reduced the quality of care in facilities across that are licensed by CMS. That would be also another good step to help prevent these undue burdens on those communities. But it really starts at the top, and it's a multi-layered, complex issue that requires delicate balancing at the state, local, and federal level. And it needs to bring all the stakeholders involved together to really address this problem. But I agree, it could definitely have unintentional consequences.
Thank you. Other questions or comments for Sam?
I had a question. Sam, great presentation. And maybe you've mentioned this in your presentation, I may have missed it, but what are the enforcement measures to keep nursing facilities accountable beyond payment to receive payments to report on communicable diseases? Can you think of any?
Currently, payment is the largest motivator, or the threat of withholding payment is the largest disincentive right now for infection prevention. For seriously egregious cases, accreditation is currently one, but it requires repeat violations and like serious death or injury to patients or a healthcare worker due to negligence. But currently, it's kind of like a case-by-case basis. They may have smaller clusters. And what we observe now is that COVID was a serious occurrence. There are other communicable diseases that happen within these skilled nursing facilities all the time that are less known about and don't make the big headlines, and they kind of slip under the radar. Patient's family, who is well connected and can advocate and really stir up a storm around. And we're usually, as I said, where CMS leads, all the other private insurers tend to follow.
Thank you.
Hey, Sam, great presentation. Question, did you look at all in this whole process of where civil liability might fit in the whole equation? You've talked mostly about enforcement mechanisms, but where does perhaps failure to report, failure to comply with these various provisions perhaps affect wrongful death and other liability questions?
Dan, can you repeat the last part of your question? You broke up right there at the end.
Okay, sorry about that. I'll turn off my camera in case the feed is part of the problem. No, I was just wondering whether perhaps wrongful death or other civil liability issues may be another de facto, if not de jure, enforcement mechanism, and to what extent does that interfere or complement the direct legal enforcement mechanisms you were talking about?
Okay. So I definitely think that they can complement them in the cases of wrongful death. I know that there are a number of lawsuits actually pending throughout the United States around negligence, around reckless endangerment, and failure of responsibilities. There's several class action lawsuits, actually. I know of some in Arizona, in Seattle, in New York. So it can definitely be a complement. That will kind of more fall under the criminal law side of things. So I'm not as versed in that, but I'm sure it can be applicable if you can find the right documentation to prove that there was negligence or a failure to act in a responsible manner.
Any other questions for Sam or for Kristy or Carrie before we call it a night? So I really want to thank all three of you for outstanding presentations and really interesting and, needless to say, timely applied practice experiences. I think it's I don't think any of you in planning your applied practice experiences were anticipating COVID-19. But I think it was really powerful how you thought about the issues of interest in a way that leaned into the current pandemic in ways that not only inform public health practice in a narrow sense, but in a much broader sense, both in terms of the impact of the pandemic, the political and policy decisions being made around the pandemic, but also more long-term addressing critical, foundational, and fundamental issues. Thank you all very much, and everybody have a good evening and stay safe.